Hey everybody, welcome back to Pulse and Probe Academies. We're going to talk about in the next section is one of the most important things in my opinion and one of the funnest things anytime I'm working in the ICU or even in the ER. And that's shock. Shock is super important because a majority of our patients present to our ICUs in shock. And one of the most important things you can do in order to treat these patients effectively and efficiently is to diagnose them appropriately. So categorize the shock as I was told in training. And so one of the things we want to do is go through each different type of shock and what that looks like from a hemodynamic perspective. And why is shock important? Well, shock by definition is basically when the body's metabolic demands are not being met by the supply of oxygen. Hence, oxygen delivery is not meeting demand. And I'll refer you guys back to the oxygen delivery equation, and we'll talk about that more in the future when we're talking about cardiopulmonary hemodynamics and other things. But that is the supreme factor that really dictates shock and how the body responds in shock. And why is this important? Well, whenever you have decreased perfusion or decrease in oxygen delivery, you're at very high risk of causing cellular hypoxia. And what hypoxia is basically it is an event where you don't have enough oxygen to drive cellular metabolism, which then induces cellular injury and even apoptosis and death. If you guys remember back to biochemistry and cellular biology back in your schooling. Now, this is a little different than hypoxemia, but we're not going to belabor that point. Because hypoxia is different than hypoxemia. But in shock, what you need to know is you have hypoxia of tissues leading to a cascade of events which causes end organ damage, cellular dysfunction, and could eventually lead to death if not treated appropriately and resuscitated appropriately. And so what I'm going to do is walk you through the 5 different categories of shock. Now, in some textbooks, you'll see 4 categories. Now, I'm going to explain to you why I put a 5th category here, primarily because I feel like it's a mix of 2 different types of shock, and we'll talk about this here in a minute. And so by categorizing each type of shock, we'll also go through the management of each type of shock, giving some specific examples as well. So let's talk about the 5 categories. So the first category of shock, and our trauma surgeons are intimately involved and aware of this type of shock because they use it every day, almost every hour, I feel like. And even us on the medicine side deal with this a lot too. We have patients on diuretics and things like that. And so this is hypovolemic shock. Now, hypovolemic shock is characterized basically by a low intravascular volume. And that can be due to a number of different factors. The first factor is obviously blood loss. And that most commonly we think of a trauma patient who's gotten in a major car accident, suffered a stab wound and is bleeding, or even somebody who's having a big GI bleed, like our cirrhotics, or somebody who has a really brisk bleeding ulcer or lower GI bleeds from like a diverticular bleed can lead to hypovolemic shock from hemorrhagic shock where you're losing blood. And then you can also, however, still have hypovolemic shock when you have low fluid volume itself, not necessarily low hemoglobin or red blood cell concentration, but just low fluid volume. One of these great examples is massive diarrhea from anybody, let's say if they have C. diff or some other type of, say, norovirus where they're having a really bad gastroenteritis can be in hypovolemic shock. Or an example I use that I experienced in my personal life is even someone on chemo who gets massive diarrhea who can't absorb enough water can go into hypovolemic shock. And that's what happened to my father when he was first started on chemotherapy. Luckily, he's doing well, but he was in hypovolemic shock after his first round of chemo and ended up in the ICU. And so what do we do for these patients who are just have low fluid volume? Well, we give fluid back. We give blood, fluids with crystalloids, other type of fluids to really improve their shock. And we'll talk more about kind of this management as we go on. And the second type of shock is distributive shock. And distributive shock is really characterized by a marked degree of vasoplegia. And vasoplegia just basically means vasodilation or dilation of your blood vessels, your veins, your arterioles. The most classic example I talk about is septic shock. We deal with this a ton in the ICU, and if my memory serves me correct, about a third of our patients that we take to the ICU are in septic shock, requiring some type of pressor support. And so there's other forms of distributive shock, which we'll touch on, but the primary driver is an inflammatory or other cellular process that causes this vasoplegia. Third type of shock is obstructive shock. And obstructive shock, just like it sounds, is you have some type of obstruction impeding flow of blood from the right side of the heart to the left side of the heart. And the three most classic examples of this are pericardial effusion, pneumothorax, and pulmonary embolism, high-risk pulmonary embolism, the way we classify it now. And so as you can imagine, the heart is kind of two separate organs, and we'll talk about that more in future topics down the road related to cardiopulmonary physiology. But the way I think of the heart is two separate organs that are interconnected and interplay and interact with each other. And so if the right side of the heart can't get enough blood to the left side of the heart of the heart's going to have a hard time and can't give enough blood to the rest of the body, of their systemic vasculature, and to the end organs like your kidneys, your liver, etc. And so you essentially have some type of obstruction, whether it's mechanical from like a blood clot or physiological due to increased pressure such as pericardial effusion and pneumothorax, causing poor right to left flow. The fourth type of shock is cardiogenic shock. So cardiogenic shock is truly kind of like an injury to the heart itself, meaning that there is some condition that has caused the heart to have some degree of decreased contractility, reducing its cardiac output and cardiac index. And so the classic example we think about is like our STEMI patients or acute MI patients that basically get a big chunk of their heart muscle knocked down, so they can't generate enough stroke volume to meet their metabolic demand, and so they go into like a shock state. We need to support them and intervene in them in some way. But other scenarios such as your heart failure with a reduced ejection fraction patient with CHF that comes in and they're just grossly volume overloaded. You've pushed them off the Frank-Starling curve to the left, and so then they basically don't have enough contractility because you've pushed them, to the right. You've pushed them to the right off their contractility curve, and so they can't generate that stroke volume and maintain their oxygen and blood delivery to the rest of the body, causing them to be in shock. There are other examples of cardiogenic shock, such as valvular abnormalities, things of that nature, but that's generally what we think of. And then the fifth type of shock that I always say is kind of a mixed picture is an upper cervical spinal type shock. And the reason why I say this is a mixed picture is because it kind of acts like a pseudocardiogenic shock and a distributive shock. And so what happens is when you knock out the cervical spine, you basically get loss of the sympathetic tone that is inputted to the rest of the body, specifically the vasculature. And so you have venous and arterial dilation because you don't have that sympathetic drive anymore. And so you get a distributive type picture, but also you get a knockout of the sympathetic input to the heart, and it's specifically the sinus node and the AV node that we talk about, which can actually cause you to be profoundly bradycardic, which then can decrease cardiac output and put you into almost like a cardiogenic shock-like state because you have low cardiac output and index. And so that's why I consider it its own separate entity in and of itself that differentiates it from lower cervical spinal shock, which is under distributive shock. Because in lower cervical or lower spinal shock, you basically do get a knockout of the sympathetic tone of the rest of the body, but not the heart. And so you have that vasoplegia and venodilation, arterial dilation of the rest of the body causing the shock state, but you don't have that denervation of the sympathetic input to the heart itself, and it doesn't cause a kind of pseudocardiogenic type component. And so now, this is kind of the way I think of each type of shock state. And I want to walk through what it would look like in each type of shock state if we were to put in a Swan-Ganz catheter or a PA catheter in these type of patients. Now, I'm going to run this with the caveat that, especially for the obstructive shock type patients, there are going to be variations in certain pressure categories based on the type of obstructive shock, whether it's PE, pericardial effusion, pneumothorax, where pressures may be elevated, etc. And I'll kind of highlight those as we go along. But if you understand and know this hemodynamic profile of any type of shock and are able to diagnose any type of shock and put the patient on the right pathway, you'll be able to understand the management from the ground level up. And so building a foundation by recognizing what type of shock it is and then understanding the hemodynamic profile will really help you and your patients as you kind of strive and work together to get towards good outcomes. And so the first type of shock we're going to talk about is hypovolemic. And so as you can imagine, you don't have enough in the tank. And so your CVP and RA pressure is low. Your RV pressure is low. Your PA pressure is low. Your SVO2 may actually be low or normal, okay, because you're not supplying enough volume to the blood or enough oxygen, and so your tissues are trying to extract as much oxygen as possible, causing it to be low. You have a low pulmonary capillary wedge pressure, a low cardiac output, but your SVR is typically high to normal because your body is trying to compensate for that low blood volume to maintain its pressure and its mean arterial pressure, and so your SVR would be high, but your PVR would be low. Okay, and we'll talk about how to treat this coming up here in a little while, but that's just the way I think about hemodynamically, that pretty much all of your parameters across the board in hypovolemic shock are low. And then you have distributive shock, okay? And so in these patients, a lot of the times their CVP can be normal, sometimes low in the initial phase, especially if they're really dehydrated, if they're septic and you have to tank them up with your fluid boluses, your 30 cc's per kg. They may be a little hypovolemic and have low pressures, but typically normal. Your RV pressure should be normal, sometimes low. Your PA pressure should be normal. Again, if dehydrated, sometimes low. Your SVO2 should actually be higher in this case. And the way I explain this, and we'll talk about this in another section of our critical care course where we talk about, again, pulmonary and cardiac hemodynamics and their interplays, is that if you imagine you have a two-lane highway, and on that two-lane highway, you have a bunch of trucks going down it, and each truck has packages on it, and those packages are oxygen. Well, on a two-lane highway, traffic is pretty easy, not congested, not too fast. And so oxygen packages kind of get offloaded at a normal pace, meaning your tissues kind of uptake oxygen at a normal pace. The packages are being delivered. It brings a normal amount of oxygen back to the delivery station or the heart. However, when you then expand that two-lane highway to a four-lane highway, such as in distributive shock with vasoplegia, then these trucks can say, you know what, there's not many cars in front of me, I could just zoom by. So they just fly on that highway. They don't unload packages as easily. They're not unloading as much. And so more oxygen or more packages come back to the delivery station, aka the heart. And so you have a higher SVO2 returning to the heart. That's the way I kind of think about it. Then your pulmonary capillary wedge pressure can be normal to low sometimes. Your cardiac output can be normal to usually initially high in these patients because they're trying to meet their oxygen demand by increasing their cardiac output and delivery of oxygen to those tissues due to vasoplegia. And the biggest hallmark of this is that they have really low SVR or systemic vascular resistance. And their PVR typically normal, but can be low, especially if initially hypovolemic. And this is how I think of the distributive type shock hemodynamic profile. Next, we have our obstructive shock. So in obstructive shock, remember, like I talked about before, you have something impeding the flow from the right side of the heart to the left side of the heart, meaning you can't get blood from the right side to the left side for some reason. And so logically, if you think about the hemodynamic profile, if we start from the right side of the heart, the cardiac output should be low, because we don't have enough blood in there and we don't have enough coming from right to left. And so the wedge pressure should be low. And so because we don't have enough cardiac output or oxygen delivery, your SVO2 should really be low because your tissues are trying to extract the oxygen that they need from the limited amount of cardiac output that they have to maintain cellular metabolism. However, now we're starting to get to the right side of the heart. And in the right side of the heart, your PA pressures are typically high or sometimes normal, depending on where the obstruction is. Now, if it's a pulmonary embolism, your PA pressure would be high because you have a physical obstruction causing increased vascular resistance within the pulmonary artery itself. But if you have a pericardial effusion or something like a pneumothorax, if you were to put swans in these, their PA catheters and PVRs may be normal. So their PA pressures and PVRs may be completely normal. So again, your PVR could be high, could be normal in these type of patients. Then your RV pressure, however, will be high in any of these obstructive shocks, and your CVP and RA pressure should be high as well. And this is kind of the distinguishing profile. And then your SVR should also be high because your body is trying to compensate from this low cardiac output to maintain perfusion pressure by maintaining its MAP. And so this is the hemodynamic profile of our obstructive shock patients. And then you have cardiogenic shock. Okay, and so in cardiogenic shock, I kind of think of it most of the time, now this isn't always the case, but most of the time like the inverse of the hypovolemic shock. So typically you'll have elevated right heart pressures, although not always, I always put a caveat, not always, elevated PA pressures. Then you have a low SVO2, because remember that highway scenario, how I told you that you have a nice 2-lane highway that's moving efficiently and you have your oxygen being delivered off of these trucks before they move to the station in a 2-lane highway? Well, now imagine you have a very high SVR in cardiogenic shock to try to augment for your decrease in cardiac output. And so that 2-lane highway now goes down to a really narrow 1-lane. And so the limited amount of trucks that are able to go on that highway that are backed up now are offloading almost all of their oxygen packages to the tissues. And so you have a low SVO2 or mixed venous oxygen sat that you obtain from the pulmonary artery. Okay, and then your pulmonary capillary wedge pressure is also high. Okay. And your PVR is typically also high too. Now, not always is your PVR high, but usually this is the way I think of it. And so really the cardiogenic shock scenarios where really all of your pressures are high, especially the left-sided pressures. Now remember, you can have isolated RV failure that causes a cardiogenic shock picture that looks similarly to an obstructive shock picture. But I'm talking in general, when we're talking about the left side of the heart, this is what we're talking about as far as a hemodynamic profile. And then, like I said, kind of the mix between all of them is that neurogenic, cervical type shock. And so remember, this is a mix between almost a pseudocardiogenic and a distributive. And so typically though, in these patients, they have normal CVPs, they have normal right-sided pressures, normal PA pressures. Your SVO2 may be normal to low, and I'll explain why. Your wedge pressure is typically normal, and your cardiac output, however, is lower because you typically have a lower heart rate. Now, not all the time is this the case, because in a young person, the myocardium can stretch and then increase your contractility and output. But this is the way I think about it, is typically you have a low cardiac output, which can lead to a low SVO2, but then your SVR is very, very low, because you've lost that sympathetic input to the peripheral vasculature, leading to gross venodilation, and then your PVR is kind of normal. And so if we know each one of these hemodynamic profiles, then we can logically deduce, well, what do we do for them? How do we treat them? When hypovolemic shock, sometimes these patients are started on pressors, but pressors in hypovolemic shock are only a bridge. They're only a bridge to what? To replacing what the patient's lost. So whether that's blood or IV fluids, IVFs, IV fluids is the way I abbreviate it here. Okay, guys? And so as long as you replace what they're losing, those patients should come down on pressors. Now, in the case of hypovolemic shock from hemorrhagic shock, where you lose blood, you have to control the blood source. That's how you treat these patients. And then also same with hypovolemic shock just from fluid loss. Now, if it's diarrhea, sometimes you have to keep up with those losses. If it's renal losses, you have to keep up with those, or treat the underlying process that caused that diarrhea, renal loss, whatever it may be. And so then you have distributive shock. And really in distributive shock, like I said before, you have some type of either inflammatory or cellular process causing cellular dysfunction and then gross vasoplegia or peripheral vasodilation, especially of the arterioles in these patients. And so the mainstay in treatment of these patients is to start them on pressors while you treat the underlying cause. Treat the underlying cause. So if it's sepsis and septic shock, you want to get source control, put them on antibiotics, give them some IV fluid, support their systems another way to give their body a chance to recover from this intense inflammatory state. And that's really the mainstay of distributed shock. Now we'll talk about first line, second line pressors, and talk later about pressor selection and what those pressors do. We'll talk a little bit more. But typically in those patients, in the first two scenarios, hypovolemic and distributed, I'll reach for levofed as my first line pressor. Then you have obstructive shock. Similarly to hypovolemic shock, really pressors in these scenarios are only a bridge to definitive treatment. So whether it's a high-risk PE where you need thrombolytics or thrombectomy, pericardial effusion where you need pericardiocentesis, or pneumothorax where you need a chest tube, really pressors are only a bridge until you get there. And so by starting them on pressors, it buys you time until you can get them to definitive management. But ultimately, you need to get these people to definitive management. And then you have cardiogenic shock. In cardiogenic shock, once these patients are in this shock state and we're able to diagnose it, then what we're looking at is really augmenting 3 type parameters. And I'm going to talk about this again in another section of the critical care course. We're really augmenting preload, afterload, and contractility. One of the biggest things we can do right off the bat is put them on an ionotrope to augment contractility, but don't forget about preload and afterload augmentation. And so that's how we help these patients really recover from cardiogenic shock as a bridge to other means, whether it's recovery, LVAD, transplant, or sometimes in rare circumstances, but it does happen, transitioning these patients to palliative care and home hospice, whether that's on a home ionotropic infusion or just general hospice or palliative care where we really focus on quality of life and controlling their symptoms and giving them as much comfort as possible. So that's really what we focus on cardiogenic shock. And then in neurogenic shock, what we really want to do is partially help improve or supplement what would be a loss of noradrenergic or adrenergic tone, and so we start them on a pressor. So you could probably use levofed, epinephrine. Sometimes in these patients we'll use vasopressin, but epinephrine, levofed, probably going to be adequate because you want to actually increase their SVR and give them some heart rate or contractility stimulation to improve this pseudocardiogenic component of this. Very rare circumstances can you intervene to get rid of this cervical neurogenic shock. I would think of rare cases like cervical hematomas or epidural abscesses, taking these patients or getting these patients to the OR as soon as possible to see if they can recover some of that cervical cord function to allow them to recover from the shock state as part of it. So I hope you guys have enjoyed going through this, and this has given you a better understanding of what each of the shock states is really telling you. And like I emphasized before, identify what type of shock your patient's in. Because if you can do that, you can elucidate these hemodynamic profiles, get them on the right treatment pathway to a better road to recovery. Now, no patient is the same, and so I always encourage you guys to individualize your care and always make sure if you're a resident, fellow, PA, NP, make sure you're doing all of this and treating patients with your supervising, either attending or other supervising senior residents, whoever is supervising you, to make sure that you're making the right decisions for the individual patient. And so kind of the next things we're going to talk about in the next few weeks is going to be pressor selection and some cardiopulmonary hemodynamics. So I hope you guys have enjoyed this. I look forward to teaching you more in the future.